To open the next session is Professor Ling Tseng, Chief of Comprehensive Breast Health Center, Chief of Experimental Surgery and Attending Surgeon of the Department of Surgery, Veterans General Hospital Taipei. He is also the President of Taiwan Breast Cancer Society, leading major clinical trials in breast cancer. Please welcome Professor Ling Tseng.
Thank you, 2020 Asia Oncology Society International Conference invite me to this session. In this session, we have 30 minutes and 2 speakers. I'm very pleased to introduce the first speaker. The first speaker is Dr. Chen, graduate from Taipei Medical University in 2005. He received internal medicine and oncology fellow training at the National Taiwan University Hospital. Then he went to Canada Princess Margaret Cancer Center as a clinical fellow, major focus in drug development program between 2013 to 2014. And currently he is the attending physician, Department of Oncology, National Taiwan University Hospital since 2014. He also is a co-member, Breast Cancer and Sarcoma Multidisciplinary Team, National Taiwan University Hospital. Also, charter member, Asia Sarcoma Consortium. In November 2019, he served as ESMO Asia Scientific Committee Sarcoma Track Co-Chair. Today, he's going to give this talk, Cardiac Toxicity and the Role of Pegylated Liposomal Doxorubicin in Metastatic Breast Cancer. Let's welcome Dr. Chen's speech.
Hi everyone, so thank you for coming for this satellite symposium sponsored by TTY. I'm Dr. Tom Chen, a medical oncologist from National Taiwan University Hospital. Today here I'm going to talk to you about the cardiac toxicities and the role of pegylated liposomal doxorubicin in metastatic breast cancer. So first talk about a structure about the pegylated liposomal doxorubicin. We're now mostly using the second generation liposomes, which has a different phospholipid bilayer vesicles, which covers the as a drug carrier and protect the drug from degradation and reducing side effects. There's also the polyethylene glycol, which we mostly called PEG, and for masking the uptake receptor sites and reducing clearance by glomerular filtration, also reducing immunogenicity. The drug within is the internal aqueous component contains the drug, and now we're using the doxorubicin for the liposomal doxorubicin. So currently there are 2 second generation liposomal doxorubicins. Now, today we mostly talk about Lipodox, which has the same approved dose with Doxio, but a longer half-life, a higher area under curve, also a better Cmax, and a lower clearance. So having this, Lipodox has a prolonged circulation duration and maintaining treatment efficacy because it's prolonged staying in the circulation. It also has decreased volume of distribution with lower toxicities. And hence, the decreased volume of distribution will shifting the drug distribution in favor of the targeted tissues where the tumors are at. Today, because of time limits, we're going to talk mostly about the differences in cardiac adverse events between conventional doxorubicin and pegylated liposomal doxorubicin. Also, the second part is the combination of trastuzumab and pegylated liposomal doxorubicin in metastatic breast cancer. So first, I'm going just to talk a little bit about the pegylated liposomal doxorubicin versus conventional doxorubicin as the first-line treatment for metastatic breast cancer, demonstrating that its efficacy has similar efficacy compared with the conventional doxorubicin. In this first-line metastatic breast cancer setting, patients were stratified according to prior adjuvant anthracycline treatment, to render pegylated liposomal doxorubicin or conventional doxorubicin. What the studies show is that both liposomal doxorubicin and conventional doxorubicin had similar efficacy in terms of progression-free survival and overall survival, as well as the objective response rates. But what we saw more important is the cardiac toxicities. pegylated liposomal doxorubicin does have a lower rate of cardiac events compared with conventional doxorubicin, as you can see from the slides, showing that the blue lines showing the pegylated liposomal doxorubicin, even with high accumulative dose, it has a lower cardiac cardiac events compared with conventional doxorubicin, with the hazard ratio showing that conventional doxorubicin has a 3.16 hazard ratio of having a higher risk for cardiac events compared with liposomal doxorubicin. And also, for patients with increased cardiac risk, what we mean by is defined as prior mediastinal irradiation, age over 65, history of heart disease, had hypertension or diabetes requiring medical treatment. And you can see from the red circle, even with those with a higher increased cardiac factor, pegylated liposomal doxorubicin does not have a significant cardiac events for patients with these high-risk factors. And the hazard ratio for conventional doxorubicin to have cardiac events in this population is 2.7 compared with the liposomal doxorubicin. So we're going to talk about a little bit why this doxorubicin has this cardiomyopathy effect, because as we know, doxorubicin is an inhibitor of topoisomerase 2. While combined with topoisomerase 2, these drugs will now inhibit the transcription of antioxidant genes. So you will have a lower electron transport proteins, you have lower antioxidant enzymes, which will have an impact on the survival of our cardiomyocytes. However, now we know the cause of the cardiomyopathy by anthracyclines at least is somehow associated with the peak doxorubicin plasma level. As you can see, in children, what we do sometimes is to prolong the infusion of the doxorubicin to decrease the cardiac toxicities, and this is shown by the figure, seeing that a prolonged infusion of doxorubicin will have a lower peak doxorubicin plasma level. So when we compare the liposomal doxorubicin with conventional doxorubicin, its pharmacokinetics, you can see that the red line is showing that liposomal doxorubicin does have a lower peak plasma level of doxorubicin compared with conventional doxorubicin. So this is also one of the important issues that liposomal doxorubicin does have an advantage in decreasing the cardiac events. And also, within the cumulative dose, as you can see, the black bar shows that conventional doxorubicin has a significant increased risk of cardiac events when we reach higher dose with more over than 650 mg per square meter. However, liposomal doxorubicin does not have this increased cardiac toxicity even with higher accumulative dose. There are also studies within all cancers, not just in breast cancers, but that with cumulative dose of liposomal doxorubicin, there is no significant decrease in left ventricular ejection function. As you can see that even with dose over for 1,000 mg per square meter of liposomal doxorubicin, there is no significant increase with the low decreased ejection fraction, even for those who already had anthracyclines. And this is also a study in ovarian cancer showing that for patients who had reached a disease control with liposomal doxorubicin in combination with other chemotherapies, then continue on with maintenance pegylated liposomal doxorubicin, showing that even with 1 or 2 years of maintenance pegylated liposomal doxorubicin, the patient does not have increased risk of cardiac events. As you can see from the red boxes, there are 2 patients within these 16 patients having received more than 5 years of liposomal doxorubicin without any significant cardiac toxicities. So I think with these data, we're confident to say that the pegylated liposomal doxorubicin does not increase cardiac toxicity as compared with conventional doxorubicin, even with a high cumulative dose. Now, in breast cancer, I think there's another important topic is for HER2 breast cancers. We now know we have good anti-HER2 drugs, especially trastuzumab and other anti-HER2 agents as well, but they also have some cardiac toxicities. So what if we combine the pegylated liposomal doxorubicin with trastuzumab? Is it possible? Do we have increased risk of cardiac events? This is the topic we're going to talk about in this section. So there's a study published in 2002 showing that mouse who has a knockout for the HER2, their cardiomyocytes is more likely to have increased stress. And also, if in these kind of knockout mice, you treat them with doxorubicin, that the patient is more likely to, the mouse is more likely to suffer from a decreased myocyte survival. And I think clinically now we already know that patients treated with a combination of trastuzumab and doxorubicin does have a significant risk for heart failure, and when these two agents are combined. So mostly in clinic now we don't combine trastuzumab with doxorubicin, the conventional doxorubicin. But if we'll give you a clinical scenario, if a 68-year-old lady who has a history of hypertension, she has a HER2 positive, ER negative metastatic breast cancer, who had already received pertuzumab, trastuzumab, carboplatin, docetaxel as adjuvant treatment. Now you have a recurrent disease. Still, she's HER2 positive. What would you think is the better companion for HER2-based antibody? So you have not used anthracycline, but this patient does have some kind of risk, and you still want to use a HER2 antibody. There's a study already done. First, this is by our Canadian colleagues, showing that the combination with pegylated liposomal doxorubicin with trastuzumab does have some role in HER2-positive metastatic breast cancer. So this is a first-line study using pegylated liposomal doxorubicin in combination with trastuzumab for 6 cycles and then trastuzumab only. And they defined the cardiac toxicity as a symptomatic congestive heart failure or more than 50% decline of left ventricular ejection fraction without symptomatic congestive heart failure. As you can see, in terms of efficacy, the combination is good with the liposomal doxorubicin plus trastuzumab having no matter whether the patient has previous experience to anthracycline in the adjuvant setting with a median PFS of 12 months. The more important thing is in terms of the left ventricular ejection fraction, the combination of pegylated liposomal doxorubicin and trastuzumab did not lead to significantly increased cardiac toxicities. There were only 3 patients who developed the protocol-defined cardiac toxicity, and no patient developed a symptomatic congestive heart failure with these 2 drug combinations. There's also another study done by our Spanish colleagues, the GAICAM group, also with pegylated liposomal doxorubicin in combination with cyclophosphamide and trastuzumab in HER2-positive metastatic breast cancer patients. So they used the 50 milligram per square meter plus cyclophosphamide with 600 milligram per square meter, also with trastuzumab as the first-line treatment for metastatic breast cancer patients. So as you can see, they included patients both had received anthracycline and had not received anthracycline in the adjuvant setting. The objective response rate was quite good with 68.8%. The median time to progression was 12 months, and the median overall survival was 34.2 months. The adverse events were mostly expected, and there were no symptomatic congestive heart failures observed, and 16.7% of patients experienced grade 2 asymptomatic left ventricular systolic dysfunction. Also, again, when you see the bar plot, the box plot for the left ventricular ejection fraction changes, there's no significant decrease in terms of heart function when you combine with the pegylated liposomal doxorubicin with trastuzumab. So in this very short time, in summary, we have demonstrated that pegylated liposomal doxorubicin has shown to have similar activity to conventional doxorubicin in metastatic breast cancer. Pegylated liposomal doxorubicin does have a lower cardiac toxicity as compared to conventional doxorubicin and should be considered for breast cancer patients with high cardiac risk in the metastatic setting. The long-term liposomal doxorubicin use is not associated with high concern of cardiac side effects as we saw in other long-term follow-up studies. And the combination of trastuzumab and pegylated liposomal doxorubicin could be an option for HER2-positive metastatic breast cancer patients. Clinical trials have not shown alarming cardiac toxicity with these two combinations. So I think that wraps up my talks, and thank you for joining.
The second speaker is Dr. Chun-Yu Liu. He graduated from Taipei Medical University and received PhD degree from Institute of Biopharmaceutical Science, National Yangming University, Taipei, Taiwan in 2013. Currently, he is a Medical Director, Division of Transfusion Medicine, Department of Medicine, Taipei Veteran General Hospital. Also is an Assistant Professor, National Yangming University, Taipei, Taiwan. Dr. Liu also is the Secretary General of Taiwan Society of Cancer Palliative Medicine, the academic committee member of Taiwan Breast Cancer Society, and the editor of Journal of the Chinese Medical Association. Dr. Liu is keen on researching the mechanism of anti-cancer drug and has performed very outstandingly. He has published more than 120 papers in SCI journals and 14 papers in the academic conference. He has received numerous domestic and international awards, including the ASCO Asia Scholar in Training Award and the Japan Blood Disease Annual Conference. Today, he is going to give the talk, Flexible Chemotherapy Strategy for Long-Term Disease Control in Metastatic Breast Cancer. Let's welcome Dr. Liu's speech.
Hello everyone, this is Dr. Liu from Taiwan, Taipei Veteran General Hospital. It's my great honor and pleasure to present my talk today, Flexible Chemotherapy Strategies for Long-Term Disease Control in Metastatic Breast Cancer. I think you're all familiar with the historical timeline of therapies for breast cancer. As you can see, the chemotherapy has been long-term used in breast cancer ever since the 1980s. You have many options including anthracyclines, taxanes, other Vinca alkaloid choice, and also other new formulation of anthracyclines. So in the previous literature review, they also known that even with the endocrine therapies or with the chemotherapy, you might get a similar benefit overall survival for metastatic breast cancer. However, if you want to achieve a long-term disease control, such as more than 5 years, actually you are more likely to use chemotherapy in the later course of the disease. So traditionally, chemotherapy lines of advanced breast cancer therapy is as the table shows. The first line, you will have a better response rate and you have a better time to progression. And in the later lines, the response rate and the time to progression will decline gradually. So traditionally, our chemotherapy scenario will be like this. You will have a first line chemotherapy, you have a one line time to treatment failure, and then the second line, third line, and so on. However, you might also sometimes have a better, more potent chemotherapy, so you get a better time to treatment failure. And then if you have a chance to move on to the earlier setting based on the clinical trials, you might get a better progression-free survival or overall survival. And then when you think about the sequencing of the chemotherapy, it became an art, and you have many things to think about. You first maybe have to think about different mechanisms and also the cumulative toxicities from the different chemotherapy regimens. So in a patient with metastatic breast cancer, from the literatures, they already say that if you can use as many as possible more chemotherapies, you might prolong the patient's survival. And also, if you have a longer PFS at the first line, then you probably get a better result. So when you use the first-line chemotherapy options, people might want to use those with the longer PFS. However, currently, among the different chemotherapy regimens, there seems to be a very similar progression-free survival. And also, you might have a similar mechanism re-challenge and using different formulations. For example, anthracycline, you can re-challenge with the different formulations such as liposomal doxorubicin. Or if you use a taxane, you use paclitaxel and then you change to another taxol, such as such as docetaxel. So in this pool analysis, we found that even you re-challenge with the liposomal doxorubicin in a previous doxorubicin treated patient, you can still have a median progression-free survival between 4 to 6 months. So there are many factors to be considered before you choosing a regimen. You probably have to think about disease-related factor, whether this metastasis is highly aggressive, such as they have many visceral metastasis, their disease interval is short, and also if they are triple-negative breast cancer. But you also have to think about patient-related factors, such as their age, performance status, their comorbidities, and their side effect, if they don't want a serious side effect. Yeah. So the recent updated ABC5 guideline also tells us that in patients pretreated with either in the adjuvant or metastatic setting pretreated with anthracycline or taxane, either you use a single agent, capecitabine, vinorelbine, or eribulin are the preferred choice. However, you can also think about other options such as gemcitabine, platinums, and the different formulation of taxane and anthracycline, such as liposomal anthracycline. And this is level of evidence 1A and with 77% of consensus. And also, interestingly, in the HER2 positive advanced breast cancer, the chemotherapy component can be in various choice. And in here, they also highlight that liposomal anthracycline can be used safely with trastuzumab. So the Pelican is the phase 3 study evaluating pegylated liposomal doxorubicin versus capecitabine as first-line treatment for metastatic breast cancer. And you can see in the first-line setting, even you re-challenge with the liposomal doxorubicin in previous doxorubicin-treated patient, you can still have a time to treatment progression around 7 months. And both pegylated doxorubicin and capecitabine are effective first-line agent for metastatic breast cancer. They have very similar progression-free survival and overall survival. And also in terms of quality of life, pegylated liposomal doxorubicin is equal to the capecitabine. But they have slightly different toxicity profile. In capecitabine, they are familiar with the hand-foot syndrome. And for liposomal doxorubicin, it's mainly myelosuppression. And for the cardiac safety, actually, pegylated doxorubicin and capecitabine are both safe. And in general, the severe adverse events are favoring pegylated liposomal doxorubicin arm. So using the liposomal doxorubicin as a first-line treatment for metastatic breast cancer, you have a phase 3 data and also have a previous randomized trials data showing that in the first-line setting, you will have a progression-free around 7 months. So pegylated liposomal doxorubicin differ from the traditional anthracycline lies in the heart-sparing effect. So we think that the cardiotoxicity can be lower, as mentioned by the previous speakers. And also there's a pulling the data from Canada and from United States for patients with gynecology cancers. The cumulative dose can be up to near 1,000 milligrams safely without cardiac event. So in general, the liposomal doxorubicin will have a grade 3 to 4 neutropenia, thrombocytopenia around less than 10%. However, the neutropenia is more equivalent, around 40 to 70%, and also grade 3 and 4 alopecia around less than 10%. So from our hospital data, we have 91 patients who has metastatic breast cancer treated with liposomal doxorubicin. You can see we have all subtypes of breast cancer treated with this chemotherapy regimen. And most regimens are in the third line or beyond. So the median time to treatment failure is around 4 months, and very similar to what literature report for the later lines of the treatment. And the patient who can have a partial response or stable disease will have a better progression-free survival. And also in a subgroup group analysis shows that patients with prior anthracycline or not does not compromise the efficacy. And whether patient have a liver metastasis also did not compromise the efficacy. And the cardiac safety is generally consistent with what reported in the literature. There are also a very unique case with 47-year-old female who has been treated as metastatic breast cancer since the age of 43 and are now in progression-free. Actually, she has been exposed to liposomal doxorubicin for more than 3 years, with the cumulative dose more than 2,000 milligram, and still have no cardiac event. So here's my summary for my talk. So the question, how many lines of treatment should we give to the patient, clearly needs further research. And we have to treat the patient as many therapeutic options as possible, either in sequencing or in combination. Because you know that even as a good, strong basketball player, LeBron James cannot always play for 48 minutes in every game. So we keep the best efficacy and toxicity balance, so considering metastatic breast cancer as a chronic disease. So in a frontline setting, a liposomal doxorubicin proved comparable efficacy with doxorubicin and also capecitabine, and provide favorable safety in the phase 3 trials. And in our real-world data, I show you that our data shows that lipodox offer around 20% response rate and near 80% disease control rate. And those who have response have a better progression-free survival, can be up to 8 months. And for cardiac safety, there's no difference between pre-treatment left ventricular ejection fraction or post-treatment ejection fraction when patients receive lipodox. Thank you for your listening. That'll be all from my presentation today.